Welcome to this postgraduate level explainer. Today, we're diving deep into the complete, high-yield clinical life cycle of a multiple sclerosis patient. Whether you're seeing patients in the neurology clinic or managing acute presentations on the wards, MS is a complex, multi-system inflammatory demyelinating disease that demands absolute clinical precision. We are covering the whole shebang, from that very first incidental MRI finding all the way to advanced therapeutics. So let's jump right in.
Here's our roadmap for today. We'll be moving chronologically through the new 2024 diagnostic criteria, mapping the disease subtypes, ruling out mimics with red flags, and then tackling acute relapse management, disease-modifying therapies, and prognosis. Let's start with the elephant in the room. How exactly did the 2024 McDonald criteria completely rewrite the rules for diagnosing MS? Because, frankly, it's a massive paradigm shift for all of us in clinical practice.
Section 1. The 2024 Diagnostic Criteria.
The foundational step here is cleanly separating dissemination in space, literally the anatomical spread of the damage, from dissemination in time. For a long time, you might remember, we needed lesions in 2 out of 4 topographies for dissemination in space. But notice the big 2024 update, it's now 2 out of 5. And for dissemination in time, we need rock-solid proof that the immune system is attacking in distinct waves. You can prove this clinically with a second attack or radiologically if you spot simultaneous enhancing and non-enhancing lesions on a single scan. Now, what is truly fascinating about the 2024 update is the formal addition of the optic nerve as that brand new 5th topography for dissemination in space. But it gets even better. Take a look at the central vein sign. Spotting a tiny vein right in the center of a lesion is a phenomenal tool to confidently distinguish MS from vascular disease. We've also got paramagnetic rim lesions, these iron rim spots that act as a glaring marker for chronic active inflammation. Oh, and in the spinal fluid, we can now officially use elevated kappa-free light chains to substitute for dissemination in time. It's a total game changer.
Section 2. Subtypes and disease course.
Let's map out the typical patient journey. It very often starts completely silently with radiologically isolated syndrome, or RIS, basically incidental MRI findings in an asymptomatic patient. Now, if they have spinal cord lesions or positive CSF bands here, their risk of converting is sky high. Then comes day 0, clinically isolated syndrome, representing their first actual demyelinating episode. Once the full criteria are met, they enter the relapsing remaining phase, which accounts for about 85% of all onsets. Fast forward roughly 15 years, and sadly, many transition into secondary progressive MS, where we see a gradual worsening of disability that's completely independent of acute relapses. But we absolutely have to separate that classic relapsing course from primary progressive MS, or PPMS. These patients experience a steady, relentless worsening of symptoms right from day 1. No early relapsing attacks at all. This makes up about 10 to 15% of cases. And here is a really interesting twist. While relapsing MS heavily skews female, PPMS actually has a nearly 1-to-1 male-to-female ratio, usually hitting a bit later, around an average age of 40.
Section 3. Differentials and red flags.
Before we lock in an MS diagnosis, we must rule out the major inflammatory mimics. For instance, if you're looking at a patient with bilateral optic neuritis and disc edema, you need to be thinking MOGAD. If they present with severe visual loss and a longitudinally extensive spinal cord lesion, you absolutely must check for aquaporin-4 antibodies to rule out NMOSD. But hey, do not forget the non-inflammatory mimics. You've got to rule out B12 deficiency. Keep an eye out for macrocytic anemia and subacute combined degeneration. Check a cervical MRI to exclude spondylotic myelopathy, and always keep post-infectious ADM in the back of your mind.
Now let's talk about the massive clinical red flags that should immediately make you rethink your diagnosis. A hyperacute presentation where the patient hits their maximal deficit in minutes to hours? That is a stroke until proven otherwise. Persistent fever, unexplained weight loss, or night sweats? Those are screaming systemic disease, not MS. And age is a huge clue here. If symptom onset is before age 10 or after age 50, it is highly atypical and absolutely warrants a deep dive for alternative diagnoses.
Section 4. Managing acute relapses.
Here is the golden rule for acute relapses. We only pull the trigger on treatment if function is genuinely impaired. Think significant motor weakness or acute visual loss. Step 1 is always high-dose methylprednisolone, typically 1,000 milligrams daily for 3 to 5 days to fast-track their recovery. If they don't respond and it's a severe steroid refractory case, that is when we bring in plasma exchange or immunoadsorption as our heavy-hitting second line. Beyond the acute attacks, managing everyday symptoms is where you truly give patients their quality of life back. Crushing fatigue, amantadine, modafinil, or methylphenidate can be total lifesavers. Spasticity is typically tackled first line with baclofen. If gait impairment and slow walking speed are the main issues, dalfampridine can work wonders. And for those really painful paresthesias, we lean heavily on low-dose anticonvulsants like gabapentin or antidepressants like duloxetine.
Section 5. Disease-modifying therapies. Okay, let's walk through the clinical strategy for disease-modifying therapies, or DMTs. It essentially comes down to balancing high efficacy against safety and convenience. If a patient comes in with highly active disease, we're talking frequent severe relapses or a heavy lesion burden, we usually want to hit it hard and fast by starting directly on high-efficacy infusion therapies. On the flip side, if they prioritize long-term safety or just really need the convenience of a daily pill, we look toward intermediate oral options. To make it manageable, we break these down into 3 efficacy tiers. Platform therapies, like your interferons, have literally decades of safety data, but they sit on the lower end of efficacy. Then you have the intermediate tier, which gives us some really powerful oral meds, but you have to be incredibly careful here. Teriflunomide, for example, is strictly contraindicated in pregnancy and requires a rigorous cholestyramine washout protocol before conception. Finally, the high-efficacy tier. Natalizumab is highly effective, but you've got to watch out for the risk of PML, so checking JCV antibodies is non-negotiable. Elmatuzumab carries real risks of secondary autoimmunity. And then there are the anti-CD20s like ocrelizumab, which is actually the very first drug approved for primary progressive MS. Section 6. Prognosis and disease evolution. When you're sitting across from a newly diagnosed patient, identifying their high-risk baseline features at day 0 is absolutely crucial. If the patient is older at onset, male, Black American, or if they have early brainstem or spinal cord involvement and a huge T2 lesion load, their risk of rapid progression is profoundly high. Conversely, a younger female presenting with just isolated sensory symptoms, that's a much lower risk profile. And speaking of our female demographic, it is vital to counsel them that MS absolutely does not impair fertility or increase miscarriage risk. Now, while relapse rates actually drop beautifully in the 3rd trimester of pregnancy, they notoriously rebound in the first 3 postpartum months. This makes planning their DMT strategy around conception a top clinical priority. I'll leave you with this final, rather provocative thought. By catching the disease in its absolute infancy thanks to the 2024 criteria, and immediately deploying these highly effective therapies, are we actually altering the immune system so profoundly that secondary progressive MS could one day become completely preventable? As our clinical tools continue to sharpen, the future for our patients has honestly never looked brighter. Thank you so much for joining me for this masterclass explainer. Keep learning, keep questioning, and I will see you next time.